Okay, hello and welcome everyone. We are so glad you're joining us here today. I'm seeing a lot of familiar names, so we're happy to have you here. I'm excited about our speaker today, Dr. Kara Donohue. I'll tell you a little bit about her. She is a practicing speech language pathologist, the director of medical speech pathology, and the director of IRAD, the Innovative Research in Aerodigestive Disorders Laboratory at Vanderbilt University Medical Center. And when I first reached out to Kara, I think I said, hey, I just read your work and I feel like everybody needs to know about it. And so here we are today. Thank you for speaking for us. I will just mention that we will do questions at the end of the session. So you can leave them in the chat and we will get to as many as we can once Kara is done presenting. Okay, thanks, Kara. You can
Okay,
go
that
ahead
sounds
and
great.
take it away.
All right, I'm going to go ahead and share my screen and then we will get going today. Thanks so much for the invitation to be here. Oops, I'll go back a couple slides here. And thanks so much for that nice introduction as well, Jenny. I really appreciate it. So let's go ahead and jump in today. And we'll be talking a little bit about prehabilitation or preventative type of exercises to help with improving postoperative swallowing safety as well as health outcomes in both cardiac surgical patients and then a little more specifically in heart transplant patients. And I'm also going to give a little bit of an overview just in general about swallowing safety and physiology in both of these patient populations and what we know in terms of their preoperative as well as postoperative swallow function at this point in time. Here are my disclosures, and let's get started. So the first study that I'm going to be talking about today is going to be something that I was involved in while I was a postdoc research fellow in the Aerodigestive Research Core Laboratory at University of Florida. And we were really interested in looking at both preoperative and postoperative swallowing safety, as well as vocal fold mobility in individuals who were undergoing various cardiovascular surgery procedures. And so, a little bit more background information here to start. So, as you may know, cardiovascular disease impacts 121.5 million American adults, and it's the leading cause of death worldwide. And approximately 7 million cardiac surgical procedures are performed in the United States annually. And this is estimated to increase by about 47% by the year 2040. And while we know that cardiac surgery is an effective intervention for cardiovascular disease, swallowing impairments or dysphagia, as well as prolonged mechanical ventilation, represent significant postoperative complications that can lead to a variety of negative health outcomes, including pneumonia, reoperation, sepsis, multi organ failure, and a staggering 15-fold increased odds of death. So, a little bit of research work that's been done recently through the Aerodigestive Research Core Laboratory looked at 182 individuals who underwent cardiovascular surgery, and we looked at the prevalence of dysphagia in this postoperative cohort. And what we found was that actually 94% of patients demonstrated unsafe swallowing. And you can see here that 65% of these patients penetrated and that 29% of these patients actually aspirated. And then when we looked a little bit closer at this data set and we examined aspirators compared to non-aspirators, we found some really interesting findings. So we found that actually aspirators had 2.6 higher odds of developing pneumonia, 5.7 higher odds of being reintubated, and 2.8 higher odds of dying compared to the non-aspirators. And then in addition to this, the aspirators on average waited 4 days longer to resume oral intake and also had a 43% longer hospital length of stay, which was associated with a $50,000 increased cost of care compared to the non-aspirators. In addition to swallowing function, we do know that vocal fold mobility impairments are a common complication of cardiac surgery that has also been linked to morbidity and mortality. So similar findings from the Aerodigestive Research Core Laboratory examined um, instrumentally vocal fold mobility impairment in 185 individuals who underwent cardiac surgery. And they found that vocal fold mobility impairments were confirmed in 25% of patients, with 7 exhibiting a complete vocal fold mobility impairment and 39 individuals exhibiting a partial vocal fold mobility impairment. And then again, when we compared individuals that had no vocal fold mobility impairment to those with complete vocal fold mobility impairment, we found some significant findings again. So we found that those that had vocal fold mobility impairments had 2.7 higher odds of developing pneumonia, 6.5 higher odds of being reintubated, and 7.3 higher odds of dying compared to individuals with no vocal fold mobility impairment. And these individuals with complete focal fold mobility impairment also had increased length of hospital stay and cost of care as well. So to date, however, no group has examined longitudinal profiles of swallowing safety and vocal fold mobility to determine the true incidence of dysphagia and vocal fold mobility impairments after surgery in this patient population. So the aims in this study were to profile both pre and postoperative swallowing safety and vocal fold mobility in patients undergoing an elective cardiac surgery, and then to determine the incidence of swallowing safety and vocal fold mobility impairments following surgery in cardiac surgical patients. We enrolled 35 participants in this study, and you can see here that the inclusion criteria was relatively broad. So essentially all adults who are undergoing an elective cardiac surgery procedure via sternotomy or extended thoracotomy, and who are willing to undergo these pre and postoperative research evaluations. Enrolled research participants in this study underwent a preoperative flexible endoscopic evaluation of swallowing examination. They then underwent their surgery, and then again, they underwent a second standardized postoperative FEES examination. And during this exam, we did a combination of standardized voicing tasks as well as a standardized bolus protocol. So a little more specifics about the bolus protocol that we used is provided here. So you can see here that we used a variety of different bolus trials, and we did map these to the IDSI levels, which you can appreciate below. For the thin liquid trials, we did use blue Gatorade, and we mixed this with white food coloring in order to improve contrast for subsequent swallow function ratings. We did terminate the FEES exams if participants had 2 episodes of gross aspiration or if they were unable to clear greater than 70% of the bolus. And then for the postoperative exams, we also required that patients were ready to participate so that they could sit upright in their bed, that they weren't requiring a significant amount of oxygen afterwards, and that their respiratory rate was less than 30 breaths per minute. We also aim to conduct the post-operative research evaluations within 72 hours of patients being extubated. Following data collection, we had 2 trained raters who performed duplicate independent ratings of swallowing safety using the validated penetration aspiration scale. And for inter-rater reliability, 100% exact agreement was required. We did have consensus meetings as needed to resolve any discrepant ratings. And then we had a board certified laryngologist who completed blinded ratings of vocal fold mobility impairments, as well as any abnormal laryngeal and anatomical mucosal findings. For the analysis, worst penetration aspiration scale score and swallowing safety categories of safe versus unsafe, as well as non-aspirator versus aspirator were used. And swallow function data were exported from REDCap into JUMP, as well as GraphPad Prism for statistical analyses and creating all the figures that you'll see. And we use descriptive statistics, Wilcoxon sign rank, and McAmers tests to perform these analyses. So as noted before, we had 35 individuals that enrolled in this research study, with a larger proportion being male and the average age being about 65 years old. You can see here by the graph on the right-hand side that there were a variety of different cardiac surgeries that individuals underwent as a part of the study. The distribution of preoperative penetration aspiration scale scores can be viewed here. And preoperatively, we can see that swallowing safety profiles were 60% safe, 34% exhibited penetration, and then 6% exhibited aspiration. The distribution of postoperative penetration aspiration scale scores can be viewed here. And postoperatively, swallowing safety profiles were 14% safe, 63% penetration, and 23% aspiration. Median worst penetration aspiration scale scores significantly worsened from preoperative to postoperative examinations. And unsafe swallowing increased from 40% to 86% across pre to post-operative time points. And similarly, aspiration increased from 6% to 23% across pre to post-operative time points. And both this increase in unsafe swallowing and this increase in aspiration was statistically significant. Preoperatively, 91% of patients had no vocal fold mobility impairments, and vocal fold mobility impairments were confirmed in 9% of patients preoperatively. Postoperatively, 77% of patients had no vocal fold mobility impairments, and 23% of individuals had partial vocal fold mobility impairments postoperatively. So we can see here that the increase in partial vocal fold mobility impairments was not statistically significant. In addition to this, no cases of vocal fold paralysis were observed in this cohort of individuals undergoing cardiac surgery. In summary, unsurprisingly, in line with other previous studies, there were significantly worse postoperative swallowing safety and vocal fold mobility impairments confirmed in this cohort of cardiac surgical patients. And there were low rates of pre-existing aspiration and vocal fold mobility impairments in cardiac surgical patients. And we actually saw a four-fold increase in aspiration from pre to post-operative time points. These findings really support the necessity of conducting instrumental swallow evaluations in this patient population to assist with mitigating adverse health outcomes following cardiac surgery. And future research is needed to delineate risk factors for dysphagia, development, and vocal fold mobility impairment in this patient population to assist with mitigating these postoperative health outcomes. And as noted previously, there has been some research work done in this area, but we hope to expand upon it more, specifically doing both pre and postoperative examinations. I just want to acknowledge the funding sources as well as the colleagues and collaborators and mentors who supported this particular research study. All right, so moving on a little bit, now we're going to talk a little bit more specifically about swallowing safety impairments and dysphagia severity in heart transplant recipients. And this is a research study that I have been working on since being here at Vanderbilt. And I'm not sure if everyone is aware or not, but Vanderbilt is actually one of the largest heart transplant centers in the world. I actually didn't know that until I started working here and then was approached by a physician who was very interested in looking at swallow function more specifically in this patient population. And when I dug into the research literature, I just didn't see that there had been too many studies done in heart transplant patients specifically. Often they get combined with other cardiac surgeries or lumped with heart and lung transplant patients. So this really sparked this retrospective research study, which I'll be talking about now. So a little bit of background information. The number of heart transplants performed annually has increased about 21.5% over the past 11 years. And there were about 4,200 heart transplants performed in 2022 alone. And heart transplantation is a necessary intervention for people with end-stage heart failure. However, pre-transplant frailty as well as post-operative dysphagia may significantly contribute to post-operative morbidity and mortality. Yet to date, there are no high-quality large-scale studies that have examined prevalence or characteristics of oropharyngeal dysphagia in heart transplant recipients to assist with speeding the diagnosis of dysphagia and mitigating adverse outcomes in this patient population. So the aims of this study were to determine postoperative swallowing safety impairments and overall dysphagia severity in heart transplant recipients, and to examine risk factors of dysphagia development and the impact of dysphagia on health outcomes in heart transplant recipients. And I will note we are still actually doing some retrospective data analysis in this project. So these are kind of current data that I'll be presenting on. So again, this was a retrospective data set. So we kept the inclusion criteria rather broad. So all adults who have undergone a heart transplantation at Vanderbilt between August 2018 to August 2023. And that's the data set that I'll be presenting on today. We are actually going back through and also extracting data from the past year. So we'll have an additional year of data of individuals who have undergone a heart transplantation soon to add to this analysis. For the study, trained raters extracted demographic and surgical, as well as swallowing data from the electronic medical record and input this information into REDCap. And swallowing outcomes included the Validated Dysphagia Outcome Severity Scale, or DOS scores, as well as Worst Penetration Aspiration Scale scores. And then we performed descriptives in JUMP and made the figures again in GraphPad Prism. So a bit of an overview. Over the last 5 years, there have been 561 adults who have undergone a heart transplantation at Vanderbilt. And of these, 34% of individuals, or 192 individuals, received an ICD-10 diagnostic code of dysphagia. So then when we looked a little bit closer and we looked at these 192 heart transplant recipients who received a dysphagia diagnostic code, we found that 57% of these individuals actually were formally evaluated by a speech language pathologist and underwent some sort of swallowing evaluation. From here, we took that information of the 109 heart transplant patients who actually underwent a standardized speech language pathology swallow evaluation here. And we looked at how many of these individuals actually underwent some sort of instrumental swallow evaluation. So either a video fluoroscopy procedure or a FEES post-operatively. And we found that 95% of individuals, so 105 heart transplant recipients, actually underwent an instrumental swallow evaluation here. So let's look at the data. The average age of the participants who underwent instrumental swallow evaluations was 57, and 77% of individuals were male. We can see here the distribution of penetration aspiration scale scores post-operatively in this group of patients. And now let's look at swallowing safety. So we can see here that 17% of individuals exhibited a safe swallow, 29% penetrated, and 54% of individuals exhibited aspiration postoperatively. On closer examination of those individuals who aspirated on an instrumental exam, 75% of individuals did so silently. So they had a penetration aspiration scale score of 8. And then let's look a little closer at dysphagia severity based on DOS score. So what you can appreciate here is that only 1% of individuals had completely within functional limits or normal swallow function, according to DOS scores. You can see here that 21% were mildly impaired, 26% were mild to moderately impaired, 22% were moderately impaired, 21% were moderate to severely impaired, and then 8% were severely impaired. What we can see here in this retrospective cohort to date is that there's a very high prevalence of swallowing safety impairments in heart transplant recipients, with 83% noted to either penetrate or aspirate during instrumental exams, and that 75% of the aspirators actually did so silently. And then again, future research is needed to help with determining risk factors for postoperative dysphagia development in heart transplant recipients to help with detecting swallowing impairments earlier and minimizing postoperative complications related to dysphagia. As I mentioned, we are still going back through the charts and extracting additional data from the past year and looking a little bit more at the swallow function of these individuals who have undergone heart transplantation in the past year. And alongside with this analysis, we are extracting a lot of other information that we hope to use to examine risk factors of dysphagia development, as well as other associations with their general recovery. Do just want to acknowledge we have this research derivative here at Vanderbilt that is very useful for doing retrospective studies such as these. And then I also want to thank some of the students, some are previous students of the IRAD lab, and then some that are current students that have really helped tremendously with going through the medical charts and extracting this data. So thanks so much to them for their help with this project. All right. So I'm going to transition just a little bit now to really be focusing on the preoperative or rehabilitation preventative type of exercise training programs. And the first study that I'm going to be talking about is again something from my postdoctoral research fellowship that I had the opportunity to work with my postdoc mentor, Dr. Emily Plowman, on. And it's doing respiratory strength training in preoperative cardiac surgical patients. And this was really a safety and feasibility study, and then also just looking at the general physiological impact in this patient population. Let's get started. So I'm just going to revisit briefly. So we've already established that we know that the prevalence of swallowing safety impairments in cardiac surgical patients is quite high. And I highlighted before some of those differences that we've observed between individuals who aspirate and those who don't aspirate. But I want to highlight one more thing which ties in really nicely with this treatment study. And that's looking at aspirators that have an effective cough versus aspirators that have an ineffective cough. And what you can appreciate here that in this prior research work, when we looked a little bit closer at our data, compared to aspirators who did not eject tracheal aspirate, those that had an effective cough response to remove aspirate from the airway demonstrated no incidence of pneumonia, reintubation, or mortality. And then they also had statistically significant shorter hospital stays, which was associated with significantly reduced costs of care. And the results of this really revealed to us a modifiable mechanistic treatment target to help with improving cardiac surgical patient outcomes. And that was to try to bolster or improve their cough function. And so that really was what sparked this research study, which was a prospective study to test the hypothesis that performing respiratory strength training in preoperative cardiac surgical patients would be safe and feasible, that it would lead to improvements in expiratory, inspiratory, and airway clearance physiologic capacity, and that it would lead to improvements in postoperative swallowing safety and other health-related outcomes. So this was a longitudinal open label pilot cohort study in 25 individuals who were undergoing a planned cardiac surgery. And individuals enrolled in the study underwent an initial research exam, which consisted of doing a variety of pulmonary function tests and cough function tests, which I'll be going over shortly. We then had individuals get set up with both expiratory and inspiratory muscle strength training devices, and we set these to a 60% load. And we had individuals perform 25 repetitions of expiratory and inspiratory daily leading up to their cardiac surgery. And you can see here that we did aim to enroll individuals who were at least 3 weeks out from their planned cardiac surgery procedure in order to allow them to gain the most benefit in terms of performing the respiratory muscle strength training regimen. Most of the therapy program was conducted via telehealth, and we did at least one telehealth session per week with individuals and then increased the resistance over time. You'll see the car on the slide, and that is because we also did home visits as a part of this study. So there was me and Lauren Wheely, who is a clinical fellow in the research lab at the time, and we did go do home visits at the midway point of treatment as well to recheck a few of those pulmonary function tests during that midpoint of their treatment regimen. Then, when individuals came back to University of Florida for their preoperative other testing, we also did that second research exam at that time. And again, we repeated the same pulmonary and cough function measures at that time to assess any changes from their baseline. And then we did also perform a standardized FEES at that point in time. Individuals then underwent surgery, and then we saw them again postoperatively for a FEES, and we tracked some information through the electronic medical record. From a feasibility and safety standpoint, we were interested in looking at the number of repetitions that individuals were able to complete of the exercises versus the amount that we actually prescribed. We did have individuals keep paper logs for this particular study. And then we also looked at the number of telehealth session or in-person sessions in the case of the home visit that individuals attended versus how many were scheduled. And then we did examine any adverse events that could be related to the intervention. We did also look at the physiologic impact. So again, looking at things like maximum expiratory and inspiratory pressure, as well as voluntary cough peak expiratory flow, and then voluntary cough spirometry metrics. And then again, we looked at their swallowing function, as well as tracking some information through the electronic health record. So as you can see here, we did enroll 25 individuals in this study, with a larger proportion being male and the average age being about 67 years old. Similar to the previous studies that I've presented on, you can appreciate that there were a variety of different cardiac surgical procedures that individuals underwent. And then notably, there were two individuals, unfortunately, that did withdraw from the study. This was due to reasons that were unrelated to completing the respiratory strength training program, but we did end up with a final data set in 23 individuals. So for those who completed the study, you can see that adherence was quite high at 98%, and that telehealth session attendance was also quite high for this particular study, with individuals being present for 100% of the scheduled sessions that we had. There were no serious adverse events related to the respiratory strength training regimen, but there were some minor reported adverse events, which can be seen here, such as pain, dizziness, a migraine, dry throat, and bloody nose. And then this graph is showing the individual change in maximum expiratory pressure across the participants who completed the training regimen. And you can see the blue lines are indicate individuals that had a change in a positive direction. And what we can see here is that about 78% of the patients improved their maximum expiratory pressure, and that they had an average increase of 17% improvement. This is a very similar chart here, but instead just looking at that individual maximum inspiratory pressure change. And we did find that there were improvements in maximum inspiratory pressure for 83% of patients that completed the study, and that the average increase was 23%. So now I'm showing a little bit more group level data. However, we do still have the individual level data here on the left-hand side in the form of spaghetti plots. So the individual colored lines are showing the change from baseline to post-treatment for each individual. And then this thicker black line is indicating that mean change from baseline to post-treatment across participants. So we did find significant pre to post respiratory strength training differences and maximum expiratory pressure. And you can see here over on the right-hand side that the average group increase was from 105 at baseline to 121. And now we're going to be viewing very similar plots again as on the previous slide, but just for maximum inspiratory pressure. So first of all, you can see the individual changes in the spaghetti plot on the left-hand side. And then we can appreciate these group differences on the right-hand side with the change on average from 73 to 88 post-treatment. And again, these were also statistically significant differences that we observed. We did also do some post hoc analysis using sex to stratify the data. And this did reveal that males demonstrated significantly greater pre to post respiratory strength training changes in maximum expiratory pressure compared to females. Um, and then notably, we did not find any statistically significant pre to post differences for voluntary cough peak expiratory flow or any of the voluntary cough spirometry metrics that we examined. So to summarize this study, preliminary data does suggest that doing a preoperative respiratory strength training program in cardiac surgical patients is safe and feasible with no significant adverse effects observed. The two study drops that we did see in this study highlight that perhaps pre-selection of appropriate individuals is important, and there might be things such as age or other lifestyle priorities that may interfere with prioritizing performing a preoperative respiratory strength training exercise regimen. In addition to this, we really need to examine demographic and operative factors that may impact response to treatment, but we do need additional data to validate and expand upon these initial findings and to conduct research in larger cohorts of cardiac surgical patients to more specifically be able to examine some of these factors. And then it's important to note the limitations of this research study as well. So, this was a relatively small pilot study with broad inclusion criteria. And because of the relatively small sample size, we weren't able to examine how demographic and surgical factors may have impacted the study outcomes. And then, in addition to this, we really don't know at this point in time what the most optimal dosage parameters are for conducting an exercise training program such as this in cardiac surgical patients. So certainly a need to expand upon this research work in future studies. Some of these potential future directions could include, again, larger scale clinical research trials in cardiac surgical patients preoperatively. I also think it would be really useful to compare respiratory strength training versus other exercise regimens in preoperative cardiac surgical patients, or perhaps combining respiratory strength training with also kind of more general exercise training programs to help bolster physiologic functional reserve in these types of patients. I also think it'd be really important and interesting to look at respiratory strength training versus more motor skill-based interventions, or perhaps doing a combination of a couple different types of exercises or treatment approaches in this patient population in the future. So again, I just want to acknowledge the funding sources as well as the individuals and mentors and colleagues who supported this research study. I'm really grateful to have been a part of it. Okay, and then last but not least, before hopefully getting to some questions from all of you, I just wanted to highlight one other research study that is currently ongoing that we started back in May of this year here at Vanderbilt. And really, again, I first became interested in working more specifically in heart transplant patients just from some conversations with some of the physicians here and just learning a bit more about this particular patient population. And so, taking the knowledge that I learned from my postdoctoral training, I was really interested in examining preoperative respiratory strength training in heart transplant recipients. So, seeing how well this could translate by conducting a larger clinical trial essentially in this patient population. So, again, really, this current study is aiming to advance prior research work by examining the impact of a preoperative respiratory strength training program on pulmonary function, airway clearance capacity, physiological functional reserve, and treatment burden in heart transplant recipients. And then also aiming to identify the impact of a preoperative respiratory strength training program on postoperative swallowing safety, physiology, and health outcomes in heart transplant recipients. So, this study is aiming to enroll 90 individuals who are actively waitlisted or currently undergoing an evaluation to be waitlisted for a heart transplant at Vanderbilt. We are enrolling only adult participants, and then essentially just anybody who's interested in participating in this study, willing to undergo the testing, to participate in the exercise training program, and that they have access to some sort of electronic device that they can connect to the internet with to do telehealth sessions. So pretty broad inclusion criteria for this particular study. For this study, we do have individuals undergo an initial research exam. And an interesting thing, kind of similar to when I was at University of Florida and individuals came from all over the state of Florida, but even a bit more so, individuals who are listed for a heart transplant often come from a variety of different states. So there's kind of a lot of logistical challenges and things that we've been learning along the way with conducting this research study. Um, but patients who are actively waitlisted for a heart transplant at Vanderbilt do come back to clinic for checkups and check-ins about every 4 to 6 weeks or so. So when they do come back to clinic, we coordinate this initial research exam with their visit. And really conveniently, the heart transplant clinic is located in the same building as our research lab. And so that really helps with getting participants to come in. So during this initial research exam, we do assessments of their breathing and cough. And then there's a couple of things that I've actually added for this study from my postdoc research study and just learning a bit more. We did add a measure of frailty, and we do also obtain grip strength from individuals in this study. We also have them undergo a standardized fees during their baseline visit for this study. And then we also have them complete a patient-reported outcome measure of their perception of their swallow function at this point in time. Um, this is a randomized sham controlled trial. So we then set individuals up with trainers for completing expiratory and inspiratory muscle strength training. And we set their trainers to a 60% load. And we're blinded, they're blinded to whether they're in the active or sham treatment group. And we are aiming for a minimal dose in this study of individuals completing 25 repetitions of expiratory and inspiratory daily for at least 2 weeks in this study. Although I will say that with heart transplants, it's unlike a planned cardiac surgery. We do not know when they're going to get a transplant. So some individuals in the study have enrolled in the study and actually gotten a transplant the same day. Some individuals have been in the study for months, so there's quite a lot of variability, but we have planned for that in the study design, and we plan to look at the duration of treatment and as a measure of dosage after the fact in the analysis. Um, Mostly, we do weekly telehealth sessions with participants. Most individuals who are waitlisted at home. However, some individuals end up getting admitted to the hospital leading up to their transplant. And so we do sometimes see people in the inpatient setting for treatment as well. And luckily, that's just a couple floors down from my office as well as the research lab here. And so it's really convenient to just pop in and see individuals for treatment throughout the week. Then, this is another tricky part of this current study. Our second research exam is going to be right before they have a transplant. And sometimes it's a really large time window, and sometimes it's a really small time window. But we do aim to repeat the same breathing and cough measures and to get that frailty index. And then we also have a patient reported outcome measure of treatment burden. And this was something I was really interested in looking at more after the study I conducted in Florida, is just getting more patient perceptions of how they view the treatment. And we're also planning to do some qualitative, semi-structured interviewing with a subset of patients enrolled in the study to gain more insight in what they liked, what they disliked, what was challenging about the intervention so that we can learn more from this current study for future more pragmatic trials. So then individuals undergo their surgery. And then following their surgery, we see them one last time for a postoperative standardized fees. We have them again complete the patient reported outcome measure of their swallow function. And then we do also track some of their information and their health outcomes through the electronic medical record. So just to summarize some of these different things that we're looking at. So again, we're looking at things like their maximum expiratory and inspiratory pressure, as well as their voluntary cough peak expiratory flow and voluntary cough spirometry. We're looking at patient report of treatment burden, as well as their swallow function. And then we also have a measure of frailty that we're obtaining in addition to grip strength to measure frailty pre and post treatment. And then with their postoperative recovery, we're looking at things like their swallowing safety, as well as physiology. So looking a bit more at some timing metrics with the FEES exams that we're doing. And then we're tracking health outcomes through the electronic medical records, such as their time to oral diet, their hospital and ICU length of stay, whether they have any significant postoperative complications, such as pneumonia development, being reintubated, getting a tracheostomy, whether they're readmitted to the hospital within 30 days, as well as their discharge status. So this study is registered on clinicaltrials.gov. As I mentioned, we did begin recruitment and enrollment for the study just in May of this year, so roughly about 6 months ago or so. To date, as of this morning, we have 35 individuals who we've recruited and actively enrolled in this study. And then 15 of these individuals have had a heart transplant and actually completed the study to date. So far, our enrollment has actually been much quicker than we had originally anticipated. So patients seem to be really interested in participating in an exercise training program before their heart transplant and seem to see the value of participating in a program such as this, which has been really cool. And so if recruitment and enrollment kind of continues at this faster rate than expected, we also anticipate that we may actually be able to end up with a larger sample size than 90 patients, which I think will be great for providing us with more information about this patient population. All right, so getting to the end of my presentation here, I just want to acknowledge the funding sources that are supporting this research work, as well as the collaborators and mentors and the research team that really assists with all the different aspects of the study. So it takes a village to really do these types of research studies. And I'm also really grateful to the clinical team at Vanderbilt. We also work really closely with our adult acute care team with this research study, and they are immensely helpful and supportive to allowing us to do this work. So that's all that I have for a formal presentation today. I'm happy to take any questions. I'm not sure if I'm able to see them in the chat or if Jenny, if you just ask
Yeah.
them for me, whatever works.
Yeah, thank you so much. That was great. And really, thank you for the work that you do and for sharing it with us. We will open the floor to questions. You guys can put them either in the chat or in the Q&A, and I'll start with one that we have here. Would you clarify how you measured the effectiveness of a cough in your studies?
Sure. So how we assess for cough in our studies is using two different ways. We do something called voluntary cough peak expiratory flow. So we use a handheld analog peak cough flow meter, and we have participants take a deep breath in, wrap their mouth around the mouthpiece, and then cough hard like there's something stuck in their throat. And that gives you a measure in liters per minute. So that's one way that we measure voluntary cough. The other way that we measure voluntary cough is by something called voluntary cough spirometry. It's mostly used in research studies just because the setup is a little bit more complicated. I didn't include images in this particular study, but I'm happy to send information your way if you'd like. But it essentially involves a power lab type of setup and then specialized software. We use LabChart and we have a pneumotachograph. And for it, you record signals. You have people place their mouth around the mouthpiece, and they just do some normal breathing to start. And then you have them cough hard like something stuck in their throat 3 times, and then just go back to normal breathing in between. And then there's ways on the back end of that that you can actually analyze um, different aspects of a cough. So, like how deeply they breathed in before their cough. You can measure um, things like cough volume acceleration, peak expiratory flow rate. Um, so it's a little bit more, I call it fancy cough analysis that we do.
Thank you, Kara. And if you
Yeah,
mentioned if anybody has further questions or wants to see any examples, you did leave your email at the bottom there, so people can reach out to you with other questions. We have another one here, and I'll read it. It says, I work for a large system, and the biggest hurdle is the system eating the cost of these devices. Do you have suggestions on how we could implement in the inpatient setting and overcome this? And if you don't mind, I'll just jump in and say that if
yeah, go for it.
you can contact Aspire us directly, and we'll be happy to try to work with you. We do offer bulk discounts. We do want to make these devices accessible. I know our lower pressure range device is covered by Medicare and some insurances, if that's helpful to the population that you treat. Other than that, I think, and Kara, maybe you can back me up on this, but bringing research such as this and showing outcomes and in the end, maybe showing what positive effects you could have in reducing future costs, in reducing such outcomes as you talked about, may be helpful.
Yeah, thanks, Jenny. I think that's a really good overview. I was going to say, in my role here at Vanderbilt, I'm also in a clinical role, and as a part of that, I do have to participate in conversations with upper leadership about, purchasing important things for various clinical settings. And I agree with Jenny that I think the more that you can bring data and information to show individuals about why it's important to have things like respiratory muscle strength training devices. I think that can really help with getting buy-in. And if you do have data, from some of these studies where we do show, this reduction in cost of care, for example, I think really learning to speak the language can be helpful about those things that they do care about. They want to know that their investment is going to be a good investment in terms of helping patients, but also be a good allocation of resources. So I think the more that you can approach it that way, the better.
Thank you, Kara. Um, our next question is, do you exclude other underlying medical conditions like respiratory issues, kidney issues, etc., emergency cases, or prolonged intubations?
Um, for these studies, we did not exclude based on a lot of other conditions in individuals. Um, I will say for the current study in heart transplant patients, some individuals are listed for a dual organ transplant. So not all of them are heart only. Some are heart liver, or some are heart kidney. We have kept it relatively broad for the most part with individuals enrolled in these studies.
Great. And then we have Dr. Donohue. Pre-op, are you doing RMST with patients who do not have speech or swallowing deficits? We are exploring prehab with some of our patients, but typically we only do RMST with communication or swallowing deficits.
Yeah, so we're not mandating that individuals have to have baseline dysphagia. Um, I know that that can be a bit different than in the clinical setting where you might not always get referrals for people that don't have baseline dysphagia. However, I will say that in doing many of these preoperative P's exams, um, I have noted that patients do have vocal fold mobility impairments and or some degree of swallowing impairment, even preoperatively. So it might not be everyone, but even in the study from my postdoc, we did see some preoperative impairments in some patients. So again, there is variability, but I will also say that many of these patients, um, I'll speak more recently to the heart transplant study at their baseline visit, do have quite weak cough, voluntary cough, and some of their pulmonary function tests are quite impaired too. So looking at the normative data, so even if they don't necessarily have baseline swallowing impairment, it is a concern for if they do develop postoperative swallowing impairment that they wouldn't have a strong enough cough to even be able to clear material from the airway. So 270 liters per minute is what we look for on like voluntary cough peak expiratory flow. And there are quite a few patients that are below that threshold.
Okay, great. Yeah, and that question was actually from Carrie, and she said PT does IMT training pre-op, which is interesting, but they're interested in a more comprehensive kind of prehab program with SLPs taking a little bit more of a lead. And I love that this is such an interdisciplinary initiative that you can kind of get everyone involved in.
Yeah, and I think there's a lot of research work we can pull from the physical therapy domain in general, doing prehab before a wide variety of different surgeries. And I think I always am telling patients too that are like in the inpatient setting, like get up and walk, like do as much as you can before your surgery because it's not just the respiratory musculature and the swallowing muscles, it's everything. I mean, there's so much research out there that really shows that patients who are bedridden for prolonged periods of time, who are generally weak and deconditioned, tend to have worse outcomes. And that includes swallowing, but a whole lot of other things. So I think it's great having that collaboration and having patients do more than respiratory strength training preoperatively too.
Yeah, I agree. Our next question is, have you looked at muscle training associated with shorter mechanical vent time?
Um, so I can speak from the study in Florida. So I think just intubation duration, that is something that we do measure. So we look at intubation duration amongst a whole host of other health related outcomes. Um, we didn't have enough power, so we didn't have a large enough sample size in my postdoc study to really look at um, the significance of some of those outcomes, unfortunately. With the heart transplant data set, that is something that I'm hoping to look at, and we should have a large enough sample size to be able to do. We just don't have enough data at this point in time, and we're technically you don't want to run any analysis when you're doing a randomized sham controlled trial. So gotta stay tuned on what we find with that. But I'm hopeful that we do find that.
Yeah, we're looking forward to that for sure. Let's see, what are some of your exclusion criteria for a patient for RMST Love the work that you are doing from Amy.
I guess I'm not sure if this just means broadly, like clinically, what the exclusion criteria would be, or for
I
research
specifically to your
studies.
study.
Okay. Um, there really aren't many exclusion criteria. Like I said, essentially anybody who is waitlisted for a heart transplant at Vanderbilt or actively undergoing evaluation for a heart transplant and who is an adult and willing to participate in the research study is able to enroll in this study. So there's not a lot of exclusion criteria. We have kept it pretty open. So there's different waitlist statuses. We had initially considered restricting it to just certain waitlist statuses or restricting it to heart transplant only. Um, but given the nature of this being a relatively newer area of research, there's only been one prior study in about 14 heart transplant patients that looked at inspiratory muscle strength training only. So since we don't know a lot, we decided to keep it relatively broad for this initial study. But that is all those different factors are things that we're tracking as a part of the study as well.
Okay, great. Thank you. Uh, on your study for patient status post cardiac surgery, what do you consider as too high of an oxygen requirement?
Um, I'm going to go back to that slide because I know I have it on my slide specifically exactly how we have it written. And I'm worried that I'm going to mess it up on this particular talk. So let me just go back in time and find that information from you. Um, okay. So we require that people have to be satting above 90%, that their respiratory rate is less than 30 beats per minute. They have to be off of CPAP and BiPAP for at least 30 minutes to be able to participate. We also didn't see individuals if they were on high flow. If they were on regular nasal cannula, we would see those individuals, but we didn't see individuals when they were on high flow.
Okay, great. And we'll take one last one. Can you speak to how you determine your exercise prescription, especially the number of repetitions?
Good question. We are using previous research studies, which have done, the standard repetitions, 5 sets of 5 repetitions. I will say I don't think we quite know what the appropriate dosage is yet. So it's similar to what I was kind of talking about for the heart transplant study, where we're going to have these really wide variability in terms of the duration that people undergo treatment. And this is something I'm really interested in exploring and even the resistance that we set the devices to. So we've chosen 60% as kind of a moderate. It's, in between maybe what we've used in ALS, which is more like 30 to 50%, and it's a little less than what we've used in like Parkinson's or maybe COPD patients, at more 75%. I think we still don't know. And I think that's something that I'm also hoping to get information from patients with qualitative interviews, because some patients are like, can I do more? And other patients, to be quite honest, with everything they have going on before a heart transplant, these people, I mean, they are very medically complex people. They have a lot of healthcare appointments. Sometimes they don't feel well. It can be really hard to even get them to do this amount per day. So I think there's both what we need to know is actually useful for patients, but then I think we also need to consider the patient population and what is a reasonable amount of exercise to ask them to do and maybe find, where do those two things intersect. So I don't have an answer for you, but it's something I'm interested in learning.
We get the question about the protocol a lot, but really a lot of times we have to say it ends up being like what the patient can tolerate sometimes. And you can have a general
Yeah,
protocol, then you may have to individualize. So we're excited to learn more in that population also. Someone
yeah.
had a question about CEUs. This presentation was not offered for ASHA CEUs, but you can use it for PDH or professional development hours, and you can check with your association how to do that if you're not sure. And aside from that, Kara, people wanted to know if you would be willing to share your reference list. So can they email you to
Mhm.
get that? Okay.
Yeah,
Uh,
absolutely.
here. And just your email again,
Oh
if you
yeah,
don't mind.
sorry.
No, no worries. Thank you.
Let me find the end of my slides again.
No worries. And this presentation will be recorded and available on demand in our Aspire Learning Center. So if you haven't signed up to be part of our healthcare professional side and have access to that for free, we invite you to do so. Please follow us on social media for updates on research and other webinars, which will be coming up. We'll be announcing our next one soon, and we hope to see everybody there. Kara, thank you so much for being here. We appreciate your time.
Yeah,
Yeah, and we're so glad to be able to learn from you.
thanks so much for having me, and thanks so much for the questions. Feel free to email me, and I'm usually pretty quick at responding.
Thank you. Have a good evening, everyone. Thank you.